Parasystole. Definition. Parasystole is a dual cardiac rhythm, in which two pacemakers compete for the activation of the heart. Clinical significance. Parasystole is a rare arrhythmia. It occurs with and without heart disease. Digitalis toxicity and sympathetic overdrive have been incriminated in some cases. Two forms of parasystole are described. Fixed parasystole, in which unidirectional entrance block completely protects the parasystolic, ectopic, focus from the effects of the dominant rhythm, usually a sinus rhythm. Modulated parasystole, in which the ectopic focus cycle length is modulated by the local cellular electric currents resulting from the basic rhythm. In both forms, parasystolic impulses can be conducted out to other regions of the heart, provided they are excitable. Parasystolic beats, or even a tachycardia, will result. It is of note that parasystole exhibits both abnormal impulse formation, ectopic focus, which could be due to any mechanism, including automaticity, triggered activity or reentry, and abnormal impulse conduction, that is, the unidirectional entrance block. Sites of parasystole. Parasystolic impulses are usually ventricular in origin, but may arise from the atria or the AV node. In ventricular parasystole, the QRS is wide, like premature ventricular beats. In atrial and AV nodal parasystole, the QRS is narrow, unless aberration occurs. Here is a comparison between the various forms of ectopic beats, premature beats, escape beats, and parasystolic beats. Premature beats are preceded by coupling intervals shorter than the basic rhythm cycle length, and followed by a pause. Escape beats are preceded by coupling intervals longer than the basic rhythm cycle length. Parasystole has three characteristics. 1. Coupling intervals are variable in fixed parasystole, but may be constant in modulated parasystole. 2. Interectopic intervals are multiples of a common denominator. 3. Fusion between the basic rhythm and ectopic beats may occur. The three characteristics of parasystole just outlined may also occur in the absence of parasystole. To prove parasystole, the presence of an ectopic rhythm, different in rate from that of the dominant pacemaker, must be demonstrated. If the rate of the normal beats is slower or temporarily depressed, then the parasystolic cycle may be measured directly by the time of appearance of two or more successive ectopic beats. Sometimes, it may be difficult to distinguish between ventricular parasystole and intermittent AV dissociation with the appearance of ventricular impulses of variable coupling intervals. Ventricular parasystole. Fusion in ventricular parasystole is usually easily detected because the two QRS complexes concerned with fusion are usually very different. Even subtle changes in the QRS complexes can be appreciated because the QRS complex is a detailed deflection, contrary to the P wave. Atrial parasystole. The coupling intervals vary less in atrial parasystole, a fixed bigeminy, closely resembling an extrasystolic bigeminy with nearly constant coupling, may occur. Atrial fusion beats are rare. Sinus node resetting and reversed coupling. In atrial parasystole, the sinus node may be reset by the parasystolic impulse, while the parasystolic cycle continues undisturbed. If the scenario is repeated and maintained, a form of bigeminy will result, called reversed coupling, in which a sinus reset beat alternates with a parasystolic beat. Reversed coupling with ventricular parasystole occurs if the ventricular impulse is conducted retrogradely to reset the sinus node. Reversed coupling tends to be transient with ventricular parasystole, but tends to persist with atrial parasystole. Interpolation. Interpolation of the ectopic impulse between two sinus impulses results if the ectopic impulse falls at a time when the tissues have recovered excitability, but when the sinus node is still refractory. The ectopic impulse will fail to reset the sinus node, and its spontaneous discharge occurs in time. pp intervals with interpolation. Incomplete penetration of the sinoatrial junction by the ectopic impulse may render this junction partially refractory to the next sinus impulse, producing a characteristic disturbance of pp intervals, in which the interval between a pair of sinus P waves enclosing an interpolated atrial parasystolic beat is longer than the intersinus interval, while the subsequent PP interval is shortened. In this figure, S1, S2, and S3 are regular successive sinus impulses, producing the P waves P1, P2, and P3. The parasystolic atrial focus after S1 created the P' wave. It partially penetrated the sinoatrial boundary, but fails to reach and reset the sinus node. The sinoatrial boundary became refractory to the next sinus beat S2, which conducted with some delay. The P1-P2 interval enclosing the parasystole is prolonged, while the P2-P3 interval is shortened. Atrial fusion. Atrial fusion in atrial parasystole is usually difficult to recognize because of lack of P-wave detail, and resetting of the sinus node. Atrial parasystolic tachycardia. If the parasystolic cycle is shorter than the sinus cycle, the ectopic impulses precede every sinus discharge, and thus take over complete control of the atria, resulting in an atrial parasystolic tachycardia, if its firing rate is greater than 100 beats per minute, that is, its cycle length is shorter than 600 millisecond. Thank you.